mentioned to you a very important clinical location in class on Monday, and that is the femoral triangle. So you will know the borders of the femoral triangle, you will know the attachments of those borders, and you will know what's present in this femoral triangle. The one piece of information that I did not walk through here with you that is probably going to be a question that you will ask yourself as you're doing this is, why in the femoral triangle does the surgeon wanting to enter into the coronary arteries enter the femoral artery and not the vein? Because there's so much more pressure in the arteries. You're going to have to wait on that one. We'll do the femoral triangle one more time whenever we get to blood vessels. So this is your first introduction to it. I would like for a student leaving me to be able, in the spring at least, to be able to walk this pathway backwards, all the way to the heart. And so we'll do that together in the spring. That's your introduction. Now, it's also interesting, before we leave this, to note the muscles here on the anterior aspect of the leg and their innervation. Remember that when we looked at the lumbar plexus, my emphasis to you in the lumbar plexus was the two major nerves coming out of the lumbar plexus we called the femoral nerve and the obturator nerve. And you can see, and when we talked about that, I said femoral you should think about as quadricep muscles, right? The muscles on the front of your leg. And obturator you should think about muscles on the medial aspect of your leg. The muscles that do adduction, the gracilis, the adductor brevis, the adductor magnus, the adductor longus. And so you can see this adductor longus, that's sartorius, this adductor longus here that we talked about last time is a border muscle here. The sartorius I'm going to show you today. We'll learn its attachments. And then we're also going to learn some of the muscles. We're going to learn the muscles of the quadriceps, the big fleshy part of the anterior part of your leg. But look, you can see the femoral nerve here in the femoral triangle. Now, what's really interesting here is that nobody ever worries when they're doing procedures in the legs about messing with the function of the quadricep. And there's a really simple anatomical explanation for that. Just so you have a context here, if you're going to do some kind of procedure in the carotid arteries, for example, in your neck, so somebody wants to go in and do something, put a stent or something in one of the carotid vessels, this is a majorly dangerous thing to do because there's a sheath there that surrounds the jugular and the carotid and the vagus. And if you touch the vagus, it will send signals to the heart and make the heart stop. So you can't just go into the carotid artery and mess around. You've got to be extraordinarily careful not to touch the vagus. But when you're in the leg, they don't care. They got the guy in the hospital room. I had a friend, a local pastor here in town at Faith Baptist Church. He had a stent put in his left anterior descending artery. And he had it done that morning. That afternoon, he was done. I mean, it's almost like an outpatient thing. It's so simple. And I said, they didn't, let me see the wound there, son. Are you okay? He said, yeah. I never even saw the doctor. So the reason for that is in this picture. Notice that the femoral nerve is not in the sheath with the blood vessels. So it's not just we don't care about the legs, it's that the anatomy is different. The nerve sits outside where the blood vessels are. So this is a really important place. Learn the borders of the femoral triangle and the contents thereof. All right, here's another shot of it. It illustrates what I was just saying. So you can see this sheath that covers the blood vessels and the nerve sitting on the outside of that. It's not that way everywhere else. And you can also see the major borders here, the inguinal ligament, adductor longus, sartorius. So let's talk about muscles then. I'm going to do the sartorius with you. So we're moving down here and on the front, on the back. This is a little out of sequence. I decided today we'll do the muscles first and I'll finish with the knee. It makes more sense that way, I think, even though the order is a little different in the presentation online. You can see these slides coming. Okay, so the gluteus maximus has attachments to the ilium, sacrum, and coccyx. The ilium, sacrum, and coccyx. That's really saying one continuous piece, yes? So the ilium, the sacrum, and the coccyx. The ilium, sacrum, coccyx, that's your medial attachment of the gluteus maximus. And it attaches to the gluteal tuberosity, which I showed you when we looked at the femur. The gluteal tuberosity is a little knot on the posterior and slightly lateral portion of the proximal end of the femur. So we looked at that when we looked at the bone. Okay, here's an interesting side note. The gluteus maximus also has attachments to the iliotibial tract. The iliotibial tract. Now, this is an interesting, and I don't have pictures in here to beat you up with all the details, but there's another muscle here called the tensor fascia. And it has fascia in its name because it has a major piece of fascia that creates the posterior compartment of the leg. And that piece of fascia extends all the way down the lateral aspect of your leg and fuses in on the tibia. You can trace this piece of fascia on a human body, on a cadaver, from the iliac crest all the way down. And the gluteus maximus actually fuses into that fascia on the side of your leg. The reason I mention it here is because it's another interesting clinical location. Your book doesn't say anything about this, but this iliotibial tract is a famous location that all long-distance runners know about. So just looking around the room, sometimes athletes who run a lot know about this. They refer to it as the IT band. And the problem with, I saw a couple smiles. So this IT band and its attachment to the tibia at the bottom does not have any cushioning on the lateral epicondyle of the tibia, which means the band itself, with every time your leg does this, the band itself rubs on the lateral aspect of the proximal end of the tibia. So a long distance runners chronically have problems with pain on the lateral aspect of their knees because of the attachment of this band, this iliotibial tract band that the gluteus attaches to here high on the posterior aspect of the body. It's an interesting side note. I like to point it out. The IT band, or the IT tract. Okay, we're not doing that part. The gluteus medius is just deep to the gluteus maximus, and it has attachments to the ilium and the greater trochanter. The ilium and the greater trochanter. Where is the greater trochanter? On the femur. We did this, right? Where is it? Lateral. Yeah, it's lateral. It's lateral and slightly posterior. So we did that with the greater tubercle and the humerus. We did that with the greater trochanter on the femur. And look at the attachments here. The minimus have the same attachments. So how in the world is a person reading the attachments of the gluteus medius and the gluteus minimus to know that these are two different muscles when the attachments are identical? How would you teach someone that?
One's deep.
Exactly. So the minimus is deep to the medius. They have the same attachments within the ilium. Okay. Now, let's do the front and backs of the legs, and then we'll do the knees, and then we're ready for an exam. Okay, so the first one here is a sartorius. Let's see if you kids have been listening to me. What is the name of that nerve right there? That is the femoral nerve. What is the name of this muscle right here? What is that? No. The gracilis is here. No. So let me draw it for you, right? I'm going to draw it. That is the adductor longus. What did I draw? The femoral triangle. Yeah, so you labeled femoral nerve. What's that? That's the artery. Yes? The artery. And then this is the vein. Femoral nerve, femoral artery, femoral vein. This is a sartorius. It's the longest muscle in the body. I had to take 2 shots of it to paste it together to get you an image of all of its attachments. You can see it's attached to the anterior superior iliac spine. What else? What else do you know is attached to the anterior superior iliac spine? It's not pictured here, but it was in the last 2 images we saw. There it is right there, the anterior superior iliac spine. And something runs across right here. And that something is it's been cut off here. The inguinal ligament, well done, from the anterior superior iliac spine over here to the gluteal tubercle. So that shares an attachment with the inguinal ligament right there, the sartorius, and then it attaches on the medial aspect of the tibia, which you can see here, attaching down here on the medial aspect of the tibia. Okay, here are the quadriceps. First, the vastus lateralis. So these are the 4 muscles on the next 2 pictures, the 4 muscles of the anterior compartment, the fleshy part of your leg on the front, the muscles that are innervated by the femoral nerve of the lumbar plexus. And they are, from lateral here, the vastus lateralis, which has attachment to the greater trochanter. This muscle is attached to the greater trochanter. The vastus lateralis is on the greater trochanter. Have I seen something else there? The gluteus medius and the gluteus minimus on the greater trochanter, right? Now, the greater trochanter is lateral. So does that make good sense that we would call this muscle the vastus lateralis? All right, now here's the next part. You might think to yourself, the vastus lateralis is anterior leg muscle. It does extension at the knee. You might think this muscle is attached to the hip. You would think the muscles that do extension at the knee would go from here to here. Now, we're going to watch for this on all 4 of them, because only one of the quadriceps actually goes all the way up to the hip. This one does not. It has attachment on the greater trochanter and on the linea aspera. Misspelled twice. The aspera, the linea aspera. Where is the linea aspera? It's on the posterior part of the femur. Okay, so this is surprising. I know that the adductors are attached to the linea aspera, and now I know that the quadriceps are as well. We're going to see it on the other side. The vastus medialis does this too. All right, so here they are. Working my way across, the next one from the lateralis is the rectus femoris, and it has an attachment on the anterior, inferior iliac spine. The anterior, inferior iliac spine. This is the only one of the 4 muscles of the quadricep that has an attachment on the hip bone. The vastus medialis, as you can see here, has as its major attachment the linea aspera. So the attachment of the medialis is actually high on the shaft of the femur, on the back of it. Well, that surprises kids to see that, the linea aspera. And the intermedius is attached on the shaft of the femur, anterior and lateral. Now, what am I missing with each one of these descriptions? I had this one on the greater trochanter, the linea aspera. This one on the iliac spine. This one on the linea aspera, and this one on the femur itself. What I'm missing is the distal attachment. And the easy part of this is all 4 of these muscles have the same distal attachment. They all attach to the tibial tuberosity. Now I'm going to skip ahead for just a minute and show you that. I'm going to come back. So skip ahead 2 slides. Here is the vastus medialis, attachment to linea aspera. Here's the vastus lateralis, attachment to greater trochanter, right? And linea aspera. So these muscles are wrap muscles. And then there's my rectus femoris right there. Now if I cut the rectus femoris off, there's one underneath it. And that one is this muscle, the vastus intermedius. So that's this one. The rectus femoris has been taken off here. Okay, so that's a deep muscle. Now, here's what I wanted to show you for the attachment. This is going to be important for our knee as we start the dissection. Notice that as the tendons of these four muscles reach the knee, they all appear to be fusing into the patella. Now, the patella itself does not articulate with any bones directly. It's a sesamoid bone, and it just sits in the knee. And, you know, you can, with weak ligaments here in the knee, the patella will move around all over the place. You can still walk. You can still do extension and flexion at the knee. So the point here is to show you all of the attachments of the quadricep muscles extend from their attachment to the patella down to the tibia, the lower leg bone. So in your textbook, you're going to see the attachment here of the quadricep muscles is the tibial tuberosity. Correctly said, this attachment is a fusion of the tendons on the patella onto the patellar ligament. So this happens in other places, and you know enough histology already to know that tendons and ligaments are the same tissue. Why would we call this structure from the patella to the tibial tuberosity a ligament when we know full well that the purpose of that attachment is for knee extension, and that extension is going to be accomplished by tendons? Well, the simple answer is, we say in anatomy, bone to bone is ligament. Muscle to bone is tendon. But you cannot distinguish them. There's no such thing as a quadricep that doesn't have an attachment to the tibial tuberosity. It is the attachment that makes the muscles functional. The attachment of the tendons fused into the patella do not do anything. You must fuse those into the patellar ligament onto the tibial tuberosity, or you get no extension at the knee. Extension happens because of the tibial attachment, not the patellar attachment. So don't get confused with the name patellar ligament. That's the tendon of the quadricep on the tibia. All right? So here's the back of the leg. The back of the leg is also four muscles. And when we learned lumbar plexus, I made a big issue out of this. I told you I'd like for you to know two nerves, the tibial and the common fibular. And I said the tibial is the big one. If you think back of the leg, you ought to think tibial. The common fibular, however, does pick up one of the heads of the bicep femoris. All right, so here we go with the hamstring muscles. So the first two we have here are the two heads of the bicep femoris, one long and one short, and thank goodness this long and short description works. The long head is attached to the ischial tuberosity. Now, circle that, the ischial tuberosity, because the ischial tuberosity is the story of the proximal hamstring attachments. So on the front of the leg, I find these things interesting. You may not find them interesting. I find them interesting. On the front of the leg, the attachment of the quadricep muscles, only one of them goes all the way up to the hip. The rest of them are attached on the femur. On the back of the leg, all of them go up to the hip. Only one of them is not attached to the hip bone. So the long head of the bicep is attached to the ischial tuberosity, and it's a lateral piece. It's a lateral muscle. The long head attaches to the head of the fibula and part of the lateral condyle of the tibia. It's lateral. This muscle is lateral. The long head of the bicep has a lateral attachment. The short head of the bicep femoris goes to the linea aspera. Okay, so what can I do? What kind of joint actions can I do with my muscle attachments to the linea aspera? When I showed you the bone, I said this. The linea aspera is the adductor attachment. Adduction. So adduction, we move the leg this way. You are pulling on the linea aspera to do that. Now today we have learned 2 of the 4 quadricep muscles are attached to the linea aspera. And the quadriceps function is to extend at the knee. So with my attachment to the linea aspera, I can adduct and I can extend, right? In addition, with my attachment to the linea aspera, I have a hamstring attachment. The short head of the bicep femoris is attached here. It's short because it doesn't go all the way up to the hip. It's a short head. So the bicep femoris, these are the two lateral strips of hamstring on the lateral portions of your leg, the long and short head. The long one goes all the way up to your butt bone. That's what you sit on, your ischial tuberosity. The short head stops at the linea aspera. So what does this muscle do? Well, it's attached to the head of the fibula and the lateral condyle of the tibia. So if it comes from here to there and it shortens, I flex at the knee. You see the linea aspera? That sounds like test question material. I can adduct with adductors at the linea aspera. I can extend with quadriceps on the linea aspera, and I can flex at the knee with attachments to the linea aspera. So I mentioned it was important, and now you're getting pieces and parts that will help you say just how important it is. On the medial side, there are two muscles. They are the semitendinosus and the semimembranosus, and notice that both of them have attachments to the ischial tuberosity, what I pointed out a moment ago. The semitendinosus goes to the medial side of the tibia, as does the semimembranosus. But I want you to notice something here on the semimembranosus, because this is going to come up when we look at the back of the knee. Look at this carefully with me. This muscle attaches to the medial condyle of the tibia. Fine. The tibia is the medial bone, right? The fibula is the lateral bone. No problem. From the ischial tuberosity, this big massive muscle all the way down to the medial condyle of the tibia. No problem. But it also has an attachment on the lateral condyle of the femur. Now, where is the lateral condyle of the femur in relationship to the medial condyle of the tibia? I'll give you lateral, but where else? What direction? What's the word? It's proximal. So the femur attachment has got to be superior to the tibial attachment, right? So what can you say about the tendon of the semimembranosus in the popliteal fossa? What can you say about it? Let's just say you wanted to go into the knee joint from the back through the popliteal fossa. Could you, in fact, go into the joint cavity without going through the tendon of the semimembranosus? You see that? It covers, in an oblique fashion, it covers over the popliteal fossa, the tendon of this muscle, from the medial condyle of the tibia to the lateral condyle of the femur. All right? So let's do the knee, shall we? Why would I call this the semimembranosus bursa? What in the world is passing across from the medial condyle of the tibia over to the lateral condyle of the femur? This labels it the oblique popliteal ligament. But a good anatomy student knows what that ligament is. What is the oblique popliteal ligament? That's the tendon of the semimembranosus. Exactly. So that's where it is. Okay. So going in from the front, a few terminology things here. The tendon of the vastus medialis we call the medial patellar retinaculum. Vocab. The tendon of the vastus lateralis we call the lateral patellar retinaculum. And as I said just a moment ago, these fuse into the patella. But is the patellar attachment of the retinaculums the functional attachment of the quadricep? No. Where's the functional attachment? Tibial tuberosity. Right. Okay?